I'm Dr. Allan Perel, and this is Conversations in Medicine. Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. It's my great pleasure to have a wonderful guest here, Dr. Tahisha Wilson, Chief of Breast Surgery at Richmond University Medical Center. And we're going to talk about, this could be an update with regard to breast disease and treatment. And I know you're somewhat new to Staten Island and you've had marvelous credentials throughout your career, and we're thrilled to have you out here. And thank you so much for coming to our show tonight. Just some statistics about breast cancer. About 1 in 8 women will have breast cancer during their lives. And what I thought was fascinating was that 85% of those patients will have no family history at all. That's right. As we think about all the genetics of this, which we'll talk about. And clearly it's the most common cancer in women. But let's talk about someone like yourself. You're an expert, you're a board-certified breast surgeon. Tell me a little bit about what it takes to become a physician specialized in this, and what was your interest and how did you get involved in it?
Great. Well, first let me say thank you so much for having me on the show. It's a great pleasure and honor to be here with you. So I am a fellowship-trained breast surgeon. So that means that I did a residency in general surgery, completed that, and then did specialized training in breast surgery. Now what's interesting is even above that, I've done a sub-specialty in oncoplastic breast surgery. And what oncoplastic breast surgery is really the marriage between cancer surgery and plastic surgery. So that means I bring a really subspecialized skill set to my breast cancer surgery.
So when patients have breast surgery, clearly they're looking for the cosmetic after the surgery to repair the process. And that's what you're saying, your subspecialty is. So not only do you take care of the cancer, but you do take care of the cosmetic portion of it.
Right, absolutely. You know, when we're dealing with a breast cancer diagnosis, it's very devastating for a patient. And I firmly believe that part of getting past the disease means that you have to feel whole and complete. And it's hard to do that if you have bad scarring or you feel disfigured. And so I'm very passionate about the cosmetic results as well as the cancer results, because I think that's integral to really getting past the disease.
Clearly I see your passion for what you do, and as a neurologist I have a passion for what I do and most physicians do. How did you become interested in breast disease?
Well, it's interesting. When I was in medical school, one of my surgical preceptors was actually a breast surgeon, and that was my first exposure, and I thought, I really enjoy this. And then when I went into training, I started doing general surgery initially, and started seeing women with breast disease and thought, I really like this. This really feels like a good fit for me. So I actually went back to do a fellowship in breast. And so I did my fellowship training and then came out doing dedicated breast surgery. For me, it's really the combination of really patient-centered care. The relationship that I have with my breast patients is very special. It's not a one-time, I operate on you and then never see you again or see you just once post-operatively. I really have a lifelong relationship with my patients. In fact, I still have patients who every year, even if they're not in my practice, if they've moved away, they will call me, they will email me and give me updates on how they're doing. So
that's
it's
lovely.
A very special relationship.
And that's so special about what you do, and especially all of us in medicine are always so taken when we get a Christmas card from someone we haven't seen in a while.
Right.
So tell me about the team approach. I mean, you're the head of the team at Richmond University Medical Center. And tell me a little bit about what group of physicians, nurses, family members, who's together when someone comes in with that diagnosis and you make the diagnosis of breast cancer?
Right, absolutely. So I've been recruited as the chief of breast surgery. And what I've been sort of charged with is putting together a best-in-class breast program. So there are two main components to that. There's the breast diagnosis side, and then there's the treatment side. And really, we take a multidisciplinary approach on both sides of that. So one of the things that we have is state-of-the-art diagnostic imaging with 3D tomosynthesis mammography.
So tell us a little bit, break that down into some words that I could understand and our audience.
Okay, so basically the gold standard technology now for mammogram is to have what's called a 3D mammo. And what 3D mammo does is, in addition to the typical mammo films, it actually utilizes technology almost like a CAT scan so that the radiologist can look at the images in many different ways. What we found with this brand new technology is that it, one, detects more cancers, and two, it decreases the rate that patients are called back for additional mammographic imaging. So it's been very, very useful.
So it's marvelous to have the state of the art. So maybe we'll take that back a step and say, what kind of screening do people need? When do women and men, if they feel something, we could talk about that a little bit later. When should women, what are the guidelines about being screened? Is there a beginning age, an end age? And tell us a little bit about it. And this is the mammographies that most of us know about and with our families or people go for.
Right, exactly. So women should be screened every year with mammography once they turn 40. Okay? If you have a family history, then you need to be screened 10 years earlier than the youngest family member who is diagnosed. So for example, if your mother was diagnosed with a breast cancer at age 46, then her daughter would begin her screening at age 36. But by and large, women without any family history should be starting at age 40 every year for mammo.
And what's the latest?
Well, that's a subject of some debate. But really, the reality is the earlier we can detect a breast cancer, the easier it is to treat. So if you're in your 80s and you're still getting around and doing well, then you should be having your mammogram every year. You know, I say once you get to be about 80, you can consider going every other year. But if you're able to do it and you're in good health, then I think you should just do it. Continue every year.
We hear about, and as a physician, again, my patients, family members, who sometimes need to do something beyond the mammogram.
Sure.
Such as MRI, ultrasound. Tell us a little bit why they need that done and what techniques and how does it help you in diagnosis?
Right. So MRI is one of the most sensitive tools that we have for diagnosing breast disease and breast cancer. But we don't do MRIs on everyone because they're so sensitive that sometimes they can pick up things and cause us to do more mammograms and ultrasounds and even biopsies to make sure that it's not really a problem. So MRIs are done selectively. So I do MRIs on patients who are high risk. So that means if they've had a breast biopsy before that's shown that they're at increased risk because they had abnormal cells, or there are different conditions that would require MRI screening. I also do MRIs on patients who are at risk because of their family history, and patients who are at risk because of genetic predispositions to breast cancer. They also get MRIs.
Tell us a little bit about, when we're touching about the genetics of breast cancer, everyone knows about movie stars, people with the BRCA gene.
Right.
Give us a little bit from your point of view. When should people be tested? Should they, you mentioned that more testing should be done, more radiographic or mammography and MRI might be needed.
Right.
What do you do differently if someone is from a family of patients who might have this? And when do you know whether to get a test for, say, the BRCA gene?
That's an excellent question. So anyone who's diagnosed with a breast cancer before the age of 50 is eligible for genetic testing. If you have more than one family member with breast cancer, then you may be eligible. Any family history at all of ovarian cancer, you're automatically eligible for testing. Any male breast cancer in the family, you get testing also. The Ashkenazi Jewish population has a higher percentage of genetic breast cancer, and so if you're Ashkenazi Jewish and you have family history, then you're also basically automatically a candidate.
Is there any other, and we talk about Ashkenazic Jews, but clearly that BRCA gene can be seen in other populations too.
Absolutely.
Tell me about ethnicity with breast cancer. Is it different in different ethnic groups? Going to African American groups, people of Hispanic origin, Asian Americans?
Right. So breast cancer is universal. Okay, so every ethnicity, is at risk for breast cancer. Very often we see the highest rates of breast cancer diagnosis in the Caucasian population. However, unfortunately, patients who are Hispanic and African American tend to be diagnosed at later stages. And that's really a problem, because what that means is that their survival is decreased. And that's why there's such a push to have people get their screening mammograms on time. Because again, the earlier we can detect this disease, the better we can treat it, and sometimes even cure people. So it's really important to catch the disease early.
I'd love to spend a lot of time talking about treatment. People hear different things, and of course you can't talk about any individual patient or person, because everybody has a different set of circumstances. The size, location, all kinds of the genetics of this. But if someone comes to you with an abnormality on a mammogram, as their routine mammogram, and you see them and you do suspect there are atypical features about the mammogram that make it look like it might be a tumor, what's your next step in diagnosis, and then we're going to spend, with your expertise, if you don't mind telling us, our audience, what kind of treatments are available? We've heard of so many different things. So tell me a little bit about someone who comes in with an abnormal mammogram. What would you do?
Right. So the first thing is, if there's an abnormal mammogram, a lot of times we do imaging also with ultrasound to confirm the finding. Some people will also need MRI to assist in diagnosis. But once we've identified that there's a suspicious abnormality, the next step is biopsy. And there are basically 3 ways that we biopsy lesions in the breast. One is using mammogram, which is called a stereotactic biopsy. We can use ultrasound, which is an ultrasound-guided biopsy, and we can use MRI, which is an MRI-guided biopsy. And basically, which method we use is dependent on which method sees the tumor the best. So once you have the biopsy, then we know what the pathology is, and pathology means what the cells are, and if they're cancer cells. Now, for me, once I have a cancer diagnosis, I sit down with the patient, I do a complete physical examination, and we have an extensive discussion about the disease and what it means and any additional studies that are required. One of the great things at RUMC is that we have a multidisciplinary breast conference. So that's a conference where I and the other experts in breast disease, we basically get in the room and we review all the breast cancer cases before any treatment is done. And so what's really special about that is that all the specialists can weigh in on treatment decisions and plans before anything has actually happened
Who'd be
to
in
the
that
patient.
group?
That's an excellent question. So we have medical oncologists, radiation oncologists, we have nurses, we have surgeons, we have breast surgeons like me, we have plastic surgeons, we have social workers, radiologists, pathologists, everyone, basically all hands on deck. Everyone who's involved in the care of the cancer patient is in the room, and we discuss all aspects of the treatment plan. And what's really nice about that is we come to consensus, and from there the plan is carried out for the patient.
So you really are getting more than one opinion when they come to your breast center.
Absolutely.
So it's not just you on one day saying, I want to do it this way, or somebody else saying that's the way I want to do it.
Right.
There's a number of professionals in the room and come up with the years of experience that you had in order to come up with it.
Right.
So if a diagnosis of breast cancer is made, how do you decide whether you're going to do small resection, large resection, taking a lot of large amount of tissue,
Sure.
whether both breasts have to be removed, whether people need chemotherapy or radiation therapy. And I know that was a big question I just asked you. but if you can give us like a little bit of pointers, because people hear all these words, and sometimes people come even to me, and shockingly, because I have so many patients as a neurologist, but they still ask me a question like, what should I do?
Right.
And clearly I defer to people with your expertise. And just to be knowledgeable about it, the idea of what choices are available. And some people are very adamant, I don't want this treatment.
Right.
And you go through the literature, and again, what's the beauty, I think, of cancer treatments in this generation compared to years ago, was there's just so many well-designed studies to try to get the answers to as many of the questions as we have. So tell us, if someone has a lesion, and most likely might come out, but tell us even how do you decide if you're going to do surgery or not?
Sure. Well, so there are many factors that go into the decision about the type of surgery that the patient's going to get. But in general, in terms of the breast surgery itself, there are two main types of breast surgery that we do. So there's lumpectomy, and in lumpectomy, you remove the cancer and the rim of normal tissue, and this is called breast conservation because you leave the remainder of the breast intact, as opposed to mastectomy, wherein we remove 98 to 99% of the breast tissue. Another big component of breast surgery is looking at disease in the axilla. So very often, some lymph nodes will be removed.
So the axilla all the way up in the armpit, all up here. Okay.
Yeah, absolutely. So the pattern of breast cancer is, breast cancer starts in the breast. Once it leaves the breast, the first place it goes is to the axilla, the lymph nodes underneath the arm. And so we need to check those usually for spread there as well. So, many different factors go into whether or not someone gets a lumpectomy or mastectomy, but there's always a consideration for the person, their family, their lives, and what's going to work best for them. So, for example, if I'm doing a lumpectomy and I know that I need to remove quite a bit of tissue, one of the things that I'll offer patients is, okay, well, I don't want you to be very asymmetric and lopsided. Maybe we can do a reduction on the other side. So that way it's easier to find bras or wear a bathing suit or look good in your clothes. These are considerations that in the past weren't even made for patients, and they were left feeling, very awkward and with the real problem when they try to get dressed and buy clothes and things like that.
Almost sounds like a simple solution, or if someone had to think about it. And I think that's the beauty also of having a lot of women in this field also, being able to think of things in a different way.
That's true. And some patients will require mastectomy for different reasons, where the tumor is placed, how large the tumor is. And for those people who require mastectomy, there are many ways now to do a mastectomy. It's not the way it used to be, where a mastectomy would be extremely disfiguring. One of the techniques that I've been doing for 10 years, and I've done hundreds and hundreds of, are nipple-sparing mastectomies. So if you remember, that's like the Angelina Jolie operation, where I can remove the breast tissue and I keep the complete skin envelope, including the nipple and areola. And this has really been revolutionary for women in terms of the cosmetics after mastectomy. Once we do a mastectomy, I work right alongside with the plastic surgeon who is in the operating room with me and immediately begins reconstruction on the breast after I've done the mastectomy. And there are many options that we have for reconstruction. Some people will choose implants, some people will choose to take tissue from their belly or their back, and there are different ways that you can do that to make a new breast. So the beautiful thing is there are so many options, and a woman can really have the opportunity to think, what works best for me and my family? They will decide different things based on how much surgery they feel is acceptable, how much time they need, how soon do they have to get back to work. All these things are considered when designing the treatment plan.
Tell us a little bit about stages. I mean, we keep on stage 1, stage 2,
Right.
in situ. Maybe give us a little bit of a blurb on each, because then we'll talk
Right.
about some of the treatments and with ancillary treatments that are available.
Okay. So breast cancer is, as you said, stage. So stage 0 is considered to be what's called ductal carcinoma in situ. So that's breast cancer that's still confined to the ducts within the breast. The stages are determined by how big the tumor is, whether or not lymph nodes are involved, and whether or not there's disease elsewhere in the body. So many times we won't know the patient's final stage until after the surgery is completed. But earlier stage is stage 1, later stage is stage 4, and stage 4 is when disease has spread elsewhere in the body. So there are many treatments that we use, and they're not only based on stage, but they're also based on tumor biology. Which brings up something, if I may.
Sure, please.
One of the wonderful advancements in the field is that we now really individualize care. So once upon a time, anyone who was diagnosed with breast cancer had the same surgery and the same treatment. Mm-hmm. Everyone had chemotherapy, everyone had a mastectomy. What we're really able to do now is consider the actual biology of the tumor and to know what kind of treatments does an individual person need. So now we are able to not give chemotherapy to women who wouldn't benefit from it, and we're able to to offer it to people who really would benefit.
Right. And you're talking about all the receptors in the breast tissue,
Right.
and watching television commercials, which is an interesting concept, that there are television commercials brought up saying what type of tumor you have, whether you have a positive estrogen receptor,
Right.
HER, all those things that we see. And even as a physician, I'm saying, really, okay. Tell us a little bit about hormone therapy in patients with
absolutely.
breast cancer.
So most breast cancers actually respond to the female hormones estrogen and progesterone, and they actually use those hormones basically to help them feed and grow. Mm-hmm. So when we have a breast cancer that is using the hormones estrogen and progesterone, what we can do is use medications to block those hormones from getting to the breast cancer. So one medication, tamoxifen, has been around for a very long time. And we still use tamoxifen mostly in women who are premenopausal. That means women who have not gone through menopause yet. For women who have gone through menopause, we use a class of drugs called aromatase inhibitors. And they are very effective. Usually when you're on hormone therapy, you're going to be on, it's a pill that you take once a day, and you're on for usually either 5 or 10 years.
Tell us a little bit about radiation therapy and how does that add to it?
Sure. So radiation therapy really goes along with lumpectomy primarily. So as I said, when I do lumpectomy, we have the remainder of the breast tissue that is in place. So we have to have a way of treating that breast tissue. So lumpectomy plus radiation, the survival becomes equal to mastectomy when we remove 98 to 99% of the breast tissue. So radiation really treats the breast and sometimes the axilla, the lymph nodes underneath the arm, when there's disease there. So, people who get radiation is really going to depend on what their pathology shows after surgery, whether or not they need it. But again, this is the beauty of our multidisciplinary approach.
You seem so expert in this field, and you are so expert. I'll say it even more than seems, and thank you so much. When we have patients out here, we're on Staten Island, and Richmond University Medical Center is on Staten Island. So many of our patients will come, and sometimes will even ask me or you directly, do I need to go to a Manhattan tertiary quaternary center for my treatment? And there were times that I mentioned to patients, yes, and I'm sure you do also. Tell us a little bit how you decide or how you advise one of your patients, whether our hospital system out here could give them the best standard of care in the world, or should someone go for another and not only for another opinion, but other treatment?
Right. That's an excellent question. And I would say that previously the answer was probably yes. But now the answer is no. Because what we have created at Rumsey is a state-of-the-art breast program where we have all the capabilities to treat as a Sloan Kettering or any other cancer center. So you can stay comfortably on Staten Island and know that you're getting the very best in surgical care, medical oncology care, radiation care, and diagnostic imaging.
And it's marvelous to hear, because people don't really want to travel far, whether they live in Brooklyn, Queens, anywhere where they're from.
Right.
So it's nice to know that we do have the state-of-the-art, research and treatment that's available. So just for a brief moment about men. Very different disease?
Well, interestingly, no. So 1 to 2% of the breast cancers that are diagnosed in men. And men present, since men don't get mammograms, men usually present with a lump in the breast. So, a man will come in and say, oh, I feel this lump here. And when we do feel something, they get a mammogram and ultrasound. Those are still the diagnostic studies that are used. If it is suspicious, then they get a biopsy. And typically for men, because there isn't much breast tissue, if they do have a breast cancer, they get a mastectomy as opposed to lumpectomy, just because there isn't breast tissue to conserve. But otherwise, it's basically treated the same.
What I'd love you to do is maybe even talk to, you've spoken to me so beautifully and eloquently, maybe tell the people out there, what would you recommend? Again, the idea, you mentioned the mammograms, getting treatment, self-examination. Right. So all those kind of things, what would you tell to your patient group out on Staten Island? And as I said, we actually air all over the city. Tell us a little bit about what you would tell them directly.
So what I would say is that everyone is susceptible potentially to develop a breast cancer. Even if you don't have any family history, if you are a woman and you have breasts, then you're at risk. And therefore, please don't ignore this very valuable screening. If you're 40 or over, you should be getting mammograms once a year. If you have any problems or concerns, please see a breast surgeon. A lot of people are scared if they feel something and they don't want to be evaluated. In reality, when women feel breast lumps, 80% of those are benign. So don't let fear stand in the way of getting help. And we are here to help you. We are here to help and guide you every step of the way in whatever it is that you need.
I can't thank you enough. Dr. Tahisha Wilson, pleasure to work with you at the hospital, pleasure to know you, and please, thank you so much for educating all of us tonight.
Oh, thank you so
much.
Thank you.